working together as we can. So thank you very much, and over to you, Mr. Braithwaite.
Very good. Right, can you see my ugly mug now or not? Very good, you can see me. Right, so I've got loads of screens here. Thank you very much for asking me to come along. As you saw from the screen before, I'm a vascular surgeon at Queen's Medical Centre in Nottingham. And for those of you who are not local, it's a fairly big tertiary referral unit. But I think most of what I'm going to say is applicable across the whole of the United Kingdom, as most vascular services have become centralised into the major teaching hospital. And a lot of the information I'm going to give you comes from NICE guidance and from the Vascular Society and from the Royal Society of Medicine. So while you're pinging up the information that you'd like to learn from this evening, I'll just get started with a few slides just to kind of warm you up, as it were, for the talk. So James, I presume that's now showing. You can give me a nod if it is. So the information that before we started was just this general assessment of leg pain in patients with peripheral arterial disease. And especially with COVID, and I assume from the primary care team in the future, you'll be taking more telephone calls or video calls with patients without them having to come to the practice. A bit on leg ulcers and the when do you actually refer to the secondary care team. And I suppose on the selfish side from the doctors and nurses in the community is how not to get sued, because one of the jobs I do is help with causation reports for patients who are suing their GP and the hospitals for why they've lost their legs or when a relative's died. So in the background, there'll be some messaging as to how to improve patient care, essentially by checking all of the areas where you might run into trouble as a primary care team. So just a little bit on how the big units are now working across the UK. Most vascular units will have a team of surgeons and radiologists, and some have got more than 8. For us locally, we have clinics in our community, well, in our district general hospitals. So it's Kingsmill Hospital in Nottinghamshire, our other main hospital in Nottingham, which is the city, and we also have clinics out in Newark, which is a small community-based hospital. And as you've already heard from Sharon, we have clinics in the Park Hospital where we'll see NHS patients as well. Consultant vascular and surgeons and radiologists are there, and they're available 24 hours a day, 7 days a week, 365 days a year. And I think one of the most important messages for the primary care team is we are always available to be contacted in some form or other. I know it's difficult for you to pick up a phone and call because you're on the telephone for hours, but if you use advice and guidance, we have a turnaround time of getting that information back to you within 1 or 2 days. And if you can't get through and you're worried about a patient, ring, because once you've had some advice from the vascular team, you've got air cover. If we've told you something and you've noted it in the patient record, then it comes back to us as the secondary care team for giving that advice. And what we also have in terms of availability of our resources is the ability to image our patients pretty much every day of the week where necessary. So I'm just going to stop there for a minute just to catch up on some of the things you want me to talk about to make sure that I'm going to be covering them. Have you got that up on the slide, James, just of the Menti? All I've got is where we're coming from at the moment. Very good. So let me just run through these things. Confirm your knowledge, hopefully do that. Confidence managing ulcers, how to distinguish, I'm sure we'll cover that. Pain management isn't really my specialty area, but I'll give you an idea of the kind of pain that some patients get and how to recognize it. Differential diagnosis, that's important. We'll try and get that covered. The duplex ultrasound we'll cover. Primary care assessments we should cover, and if not, I'll point you to areas. Patient management in the pre-hospital feed, antibiotics, might not be able to cover that, but I will point you towards a NICE guidance and the referral guidance. So good, so you don't want me to talk to you about heart surgery, that's excellent. So we've got the right person talking to you. So if we'll flip back now just to the slide deck for a minute, just to bring you up to speed about what we're actually talking about, take you back to medical school for a while. So we're talking about the majority of these patients are those who've suffering from atherosclerosis. So as you'll all know, they're older people, they've got hypertension, they're smokers, they've got diabetes. And you'll see from that slide, they're the conditions that they develop. But now let's just talk about what I can cover this evening. I'm not going to do stroke because that's something that's usually there's some very good pathways into the stroke services. I'm not doing angina and heart attacks. Claudication, and this is one of the asides I'll give you. I don't know whether you know where the term claudication comes from, but it's actually named after the Roman Emperor Claudius, who used to limp. And so when you that question about why is my leg hurting, doctor, there are three main reasons for the leg hurting that I might deal with as a vascular surgeon. There's obviously arterial claudication, which is when there's not enough blood getting to the muscles to allow the patient to walk. There's neurogenic claudication, and that's often the thing we're asked to differentiate because they're usually the same age group, elderly patients. And in patients who've had a deep vein thrombosis, they may have post-thrombotic syndrome, and that can give them something called venous claudication. So one of the questions that you guys have set me is how do you differentiate between them? So if we talk about vascular claudication, it is pain when somebody walks, and it's consistent. And I usually joke and say that I say to the patient, when do you get the pain? And they say, I get pain in my calf. And I say, where? And they say about 200 yards away from the cigarette shop, because that's where they're walking to. And if you were to say to your patient, when you're doing the telephone call, the video call, do you always end up stopping at exactly the same tree, the same bench, the same wherever? And if every day they're stopping at the same point and it's the calf that hurts, then it's most likely they've got vascular claudication, especially if they're a smoker with hypertension, diabetes and the like. If when they push it, they're getting pain in their thigh and calf, then it means that they've probably got a narrowing of the artery higher up in the femoral artery. And if it's then their bum, their thigh and their calf, then it's going to be a problem up in the iliac artery. But it will always be consistent, and they'll tell you that. Now, to differentiate from neurogenic claudication, and this is the key word, key phrase I would say to patients, is do you have some days that are better than others? And if a patient says, oh yeah, some days I can walk really well, and other days I can hardly walk at all, it's more likely to be a neurogenic cause. And if they say that, then you need to say, well, do you get back pain as well? And do you have problems walking up slopes and the like? And they're the triggers that will tend to push the diagnosis to be more likely to be neurogenic. And for venous claudication, well, that's going to be someone you just need to ask, have you ever had a deep vein thrombosis, been on warfarin, been on anticoagulants and the like? So the key thing when asking is, do you stop at the same point? Now, when it comes to referring those patients, it's a very binary in my view, is if you say to the patient, at night time, do you ever get pain in your feet? Do you ever get tingling in the feet? And you've got to think about the diabetics because they can have a neuropathy. But if they sleep reasonably well and they don't have pain, and if you say to them, could you look at your foot and have you got any black bits? And in fact, you could ask your patients nowadays to take a photograph. And that's a theme that I tend to advise a lot of primary care teams is take pictures. And if necessary, actually get the patient to take the picture on their phone and email it to you, because that then sorts out all the information governance issues we have. If they've sent you the picture, it's their responsibility and you don't have to have special consent. Anyway, so going back to when to refer, if they have no problems at night time and there's no numbness and tingling and there's no black bits on the toes, most patients with claudication can be managed in the community. We're not really interested in seeing patients with claudication unless it's severely affecting their lifestyle. So before referring, just think, what do you want the consultants and the team at the hospital to do? Because we're probably not going to deal with a claudicant who's still smoking. You've got to turn around and say to them, look, guys, if you carry on smoking, you're probably going to lose your leg. And that's up to 20% of patients with claudication who continue to smoke. And I think you can read them the Riot Act and say that the vascular surgeons are unlikely to touch you. You need to stop smoking. And when you've stopped smoking, you then need to be walking for 30 minutes twice a day, every day. And you need to do that for 3 to 6 months. So if you're looking to make the perfect referral to the vascular team, it would be, dear doc, please will you see this patient with very short distance claudication, severely affecting their lifestyle. They've stopped smoking, they're on aspirin, we're controlling their blood pressure. They've been walking for 30 minutes twice a day, every day for the last 6 months, and they're getting really fed up. Can you help them? And then we'll put them through the vascular pathway. Okay. So the perfect vascular pathway, ideally, and this is you guys up in the top left-hand corner, the primary care team. You'll do what I've just said. You'll refer the patient, and we'll then end up doing a duplex scan, which someone wanted to know about. And the duplex scan is actually probably our most important technique for investigating. And the reason for that is that in the space of half an hour, we can actually scan an entire leg, work out where any occlusions are if it's arterial disease, and we can work out where any venous disease, if it's a venous problem you're referring to us. And so for those patients with claudication who are really suffering, that will be our first line imaging. So I'm just going to stop there about claudication and leg pain, and hopefully that's fixed it in your mind as to when to refer patients with pain when they walk. As a slight aside, if we think it's neurogenic, we'll actually put them on a treadmill and measure their blood ankle pressures before and after they walk. And if there's a drop, it's likely to be vascular. If there's no drop in ankle pressures, then it's probably neurogenic, and the place to send them is the neurosurgeons for an opinion. So having paused on that, let's talk about the more severe problems, and they're the patients with significant arterial disease. Now, I'm going to just flip through a couple of slides, because what I've seen and listening to GPs, and in terms of getting sued and having the legal side, it's nearly always when the primary care team has failed to examine the patient's foot. And not only is when they've failed to examine the patient's foot, it's also they've failed to actually be very binary on their findings. And the next slide, I'll just tell you a bit more about that. Now, a game you might want to play, because I've been playing with these words, is failure to feel the feet could result in a failure and forfeit. So that's kind of litigation and the like. Failure to save the patient's leg. And you can put as many F words as you want to in there to just make you remember that if you see a patient and you suspect vascular disease, you must feel for the pulses in their feet. If you fail to do that, you'll end up with a patient who may well suffer as a result. Now, when it comes to feeling for pulses, and please excuse me if I'm about to insult you, but there is no such thing as a weak pulse. That's for medics and cardiologists, and oh, it's a bit weak. You can either feel it or you can't. Very binary. Don't go wishy-washy. And what I tend to say when I'm helping to teach the medical students is double or quits on their student loan. Because nearly every time I say that, they say, ooh, well, it isn't there. And if you can't feel it, it is not there. And the people who've ended up running into trouble, both patients and GPs who've been sued successfully, is that they've been wishy-washy about it. If you've got a patient with significant arterial disease and there's an absent pulse, you must refer them to the vascular surgeons. And what I mean by significant problems is if they've got pain that's there all of the time, or there's bits missing and the patient wants to have something fixed. So when I've done this kind of talk, when there's a whole auditorium full of doctors and nurses, is I've actually usually got one of the GPs up on the table at the front to show them how to feel pulses. So I want to imagine you've been asked right to the front of the auditorium, you've had to take your trousers off and you're up on the couch, and this is how you feel for pulses. That's the posterior tibial pulse. 2 fingers, if necessary, use 3 fingers. midway between the medial malleolus and the point of the calcaneum. And you should be able to feel the pulse there. And then if you're looking for the Dorsalis Pedis, you've got to basically pull up the, get the patient to pull up their big toe. You'll feel the extensor longus tendon, and it's just on the lateral side of that is where you feel for the Dorsalis Pedis. And if you can't feel them and the patient's getting pain in their leg, you have got to think they've got a vascular problem. No matter their age, I've had 40-year-olds lose their legs because the GPs have been managing their pain as sciatica. So if you diagnose sciatica, you can only do it once you've examined the patient's pulses. And especially in the era of COVID, we're seeing younger patients with thromboembolic complications. One last thing that comes up in the medical litigation is capillary return. Lots of people say, oh, they had good capillary return. It's actually been demonstrated to be not a good way to assess blood supply of the foot. And we've got some slides later on which show you some different coloured feet. And some of them will get a very brisk capillary return, but it's not arterial return. It's to do with venous congestion. So don't rely on capillary return. That's for when the patients are in the emergency department and we're assessing degree of shock and the like. So how are we doing for questions or comments coming through, James, for now?
Yeah, so a few questions. I've certainly learned a lot already. So a little bit about ABPI. So we talked about the duplex scanning, but at least in our guidance and things that we can do in primary care, we're advised to ABPI. And there's been a couple of questions. So how do we interpret ABPI, and particularly if it's above 1, because it's a little vague in our guidance and it says, you know, think diabetes. I think it's pretty much what it says. And then there was a bit of a question about when checking for pulses, is a Doppler, you know, using a Doppler scan, a handheld one, would that be a helpful thing to help determine whether a pulse is present or not? Or if we're having to use a Doppler to find it, is that so weak that there might be a problem?
Okay, well, they're two really good questions, and you're not alone in asking them. Every GP group I kind of listen to ask the same thing. So let's just talk about Doppler. Okay, one of the previous slides, a pulse is something you feel. And if you can feel a pulse, and you can actually, and you double or quits on your massive GP salaries and the like, if you can feel that pulse, the patient is highly unlikely to have major arterial disease. So they don't need an ABPI because you can feel the pulse. If you can feel a pulse in the foot, the ankle pressure will be 1 or greater. If you can't feel a pulse, and then you put a Doppler probe on, that is not a pulse. That is a signal. And where things go wrong is people say, I could hear a Doppler pulse. And people hear the word pulse and then automatically think they must have good blood supply. A patient with arterial disease will have a Doppler signal. Now, for those of you who've got the handheld Dopplers, by all means, you can listen because it might help reassure the patient, because if they can hear, this is where I do bird impressions as well, is if they can hear whoosh, which is a triphasic signal, and you can play it at home with your friends and family if needs be. If you can hear that signal, they will have a pulse. If, however, you hear a sh, 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 then that patient has got more of a monophasic flow, and they will have upstream problems. And if they're complaining of pain in their foot, or they've got bits missing off their foot, they need to be referred to vascular surgery for a duplex scan. Now, ABPIs, there is a lot of confusion about ABPIs because it was our first line test before we had duplex scans. And there was a bit of range of opinion on this. A lot of consultants will say, well, do an ABPI, please, because it'll help. But I would argue if an ABPI is 1 or above, and you've got a foot pulse, well, you're unlikely to have vascular disease. If the patient is diabetic and you can't feel the foot pulse and their ankle pressure is above 1.2 and the noise is a bit shh, shh, then that's because they've got very calcified vessels and you can't crush them. But it should be the fact that they're diabetic, you can't feel a pulse, and they've probably got something wrong with their foot. That should be triggering the referral, not necessarily the fact that their ankle pressures are abnormal. In my view, ankle pressures are really important before you put compression onto a patient. So that's more for venous disease. The ankle pressures probably shouldn't, in my view, be used for arterial disease. You should be doing a duplex scan, or not you guys, but because you need the people who are doing it 700 times a year. So if there's a patient with no pulse and they've got significant symptoms, pain in the foot, numbness, they need referring to the vascular unit. And that will bring me back to this ideal process. Is that patient would be referred to the vascular team, and in Nottingham we can offer this service every day between 8 and 5 during the daytime. They would have their legs scanned, and if we found there's no arterial disease, then they'll get sent back to primary care saying it's okay, there is no significant arterial disease, this is what you need to do. And I suppose diabetes is one of the big problems we've got, but a lot of diabetics have good blood supply, but they may have a leg ulcer or an ulcer on the toe. And certainly there's a big move now from some of the better vascular units to be offering a service where any patient with diabetes and an ulcer, they should all have a duplex scan right at the beginning of the process. Because if we turn around and say there's no arterial disease, then the primary care team and the endocrinologists can manage the patient with offloading with the podiatric team and use of antibiotics. Because where the failings happen is when the patients, first they get seen by the GP or maybe the nurse tries some dressings, a few antibiotics, then they get sent to the podiatric team. And meanwhile, the disease process is continuing and they start losing more of the smaller blood vessels in the foot. And then someone says, oh, I wonder if this is arterial. Then they get to us, and then by then we've missed the boat. And there's some quite important work coming out of both Leicester and Bristol, which is demonstrating if you get the patients with diabetes seen by a vascular team at the beginning, then actually you save more legs because we deal with the process. So we revascularize very early. And there's some guidelines that come out from the Vascular Society, which I'll flip to in a minute, and basically get the vascular tree examined early on. I've got to balance that with there's only so many vascular scientists and surgeons, and if we had every patient with diabetes coming through the door, we'd be snowed under. But I'll bring you back to, if they've got diabetes and a foot pulse, you don't have a vascular arterial problem. So keep it in the community. If they've got diabetes, a vascular problem, and you can't feel a foot pulse, you've got to get them seen by the vascular team. And at worst, a telephone call or an advice and guidance saying, I've got this problem, can you help? And then, as the phrase is, the monkey's on our back as a vascular team to help sort that patient out for you. So just flipping on as to what we think the future is going to be with arterial disease, and this is something that's come from the Vascular Society, and hopefully this will be the future for how we manage together these patients. From primary care's point of view, look at this bottom area here, is that if you've got a patient who's got stable arterial disease, in other words, you know they've been having claudication for some time, and one of their toes has gone black, and this would probably be someone who's not diabetic, and you want some advice, well then ideally you need to see a vascular surgeon today, or tomorrow. So you refer, hopefully we will see them in our surgical assessment unit. We'll do some scoring. Wi-Fi is not to do with the internet. It's a Wi-Fi score is actually a staging as to how serious the patient's foot disease is. And then we'll decide if they need intervention. So that will be the future of managing these patients, is early vascular assessment, which should, in theory, reduce the number of patients who start losing their forefoot and parts of their leg. So I've digressed a bit from the question. So if I now bring you back to the ABPI issue, interpretation is really for, you know a patient's got arterial disease because you can't feel the pulse. If their ankle pressure, if you did measure it, was 0.7 or above, then that patient is probably suffering from intermittent claudication. Anything from 0.7 down to about 0.3 or 4 they might be getting some pain at night. Anything below 0.3, then they've actually got critical limb ischemia, and you're pretty much mandated between 0.3 and 0.5 to refer to vascular surgery. So if you like using ABPIs, they would be your cutoff. So anything below 0.5 probably needs to see a vascular surgeon. But I'd argue you need to be listening to what the patients are telling you and what it is they want. So hopefully that answers those questions about ABPI and Doppler as to their use in the community. So James, any more things come up?
Fantastic. So there's a couple here that have come similar to this slide we're looking at now at the moment, actually. So Amy's asked, and when we do diabetic foot checks, if we can't feel pulses, but they have normal sensation and no pain, do we need to panic? And Fairace, apologies if I mispronounced that, says, how urgent is a patient with no pulse but with some pain? I assume not unrelenting pain, but intermittent pain. How quickly should they be referred? Same day referral or urgent referral? Because from your diagram there, it looks as if it needs to be same day, but I wonder about capacity issues, because I must say, in times when I've referred, it hasn't been quite as immediate as
No, that's right. So I mean, they're really good questions. Again, this is the ideal. If you're the patient, this is how you'd like to be managed. We've got the resource issue. So in terms of, if the patient has no problems in their foot and no pulses, so in other words, they've had the neurological assessment, you don't need to do anything because the patient's not got a problem. Don't send us patients who don't have a problem, because we're not going to correct something in the preventative. That's going to be all about education to make sure that they cut their nails properly, they look at their feet on a daily basis and take the small bits of Lego out from underneath the sole and things like that. So we only need to see patients who are starting to get complications. I mean, for further information on how to manage this, if you look at NICE guidance and the links that's going to be sent out after this meeting, if you read through that, NICE has got some very clearly defined pathways, and you can just literally go down it and say, well, I followed NICE guidance and this patient's at this stage, they must be referred now. So that's in terms of if there's a pulse, no symptoms, if there's no pulse, I beg your pardon, but no symptoms and no bits missing, they do not need referral. They just need normal foot management. What was the second one?
It was about how urgently should we refer people who have sort of got symptoms either slowly progressing, but I would expect without sort of evident critical ischemia type symptoms.
Okay, so this can be quite tricky, especially with diabetics, because neuropathy can be quite painful for patients, and I'm sure you've all got patients who've had diabetic neuropathy. And this goes back to the assessment of the foot. If the patient's not got constant pain, it's unlikely to be ischemia. You've got to think something neurological. But if they've got no foot pulse and they have got pain, I would argue it is safer to make the choose and book, not the choose and book, I beg your pardon, the advice and guidance, and say, I've got this patient, this is the scenario. Do you think they should have a vascular assessment? Or please, will you assess their vascular tree, because I'm worried about them. And then it's dumped on us, and that gives you as the air cover in the primary care, that I asked the question and the vascular surgeon said, okay, well, we'll wait a month, and then it got worse. So that's what I would really, advice and guidance is not intrusive. The on-call team will just get them coming through and then they'll respond to them. And it is the way for us to work as a team between primary and secondary care.
Fantastic, thank you. And we'll send photographs as well with that advice. Yeah, that's all for the moment. But please keep the questions coming in the chat and we'll make sure we get them asked.
Right, well, I'm just going to bring you back to the suing bit, because that's, again, that's personal, and those GPs I've had to talk to as part of the legal process, it could be quite distressing actually to have a patient that you've cared for end up suing you. And I've certainly had GPs in tears in the lawyers' offices over outcomes. But this is I probably do between 60 and 100 reports a year. About half of them are from the Medical Protection Society or the NHS litigations, because I tend to do a lot of I tend to want to be engaged on defending the medical profession rather than going out and helping the claimants, but I do some claimant work. But these are the main reasons. So we can go through. I've already said, and it was all the F words, if you don't examine the patient's feet and they end up losing bits and usually losing a leg, almost certainly the GP expert will say there was a breach of duty. So you must, with these patients, feel for those foot pulses. And I'll keep bringing you back to, if it's not there or you can't feel it, it's definitely not there. It's not the fact you're not very good at it. The other thing, and I work for the NHS, so for the Clinical Advisory Service, where doctors in general go wrong is failing to actually think about another cause. We all can be very guilty of getting honed down onto one problem. And this is a slight aside, it's not just arterial. A GP, there was a young man, 42 years old, he was a university lecturer, good runner, nasty cough and cold, laid up in bed for a while. Father, he was a smoker, his father had had lung cancer. GP sent them off for a chest x-ray. It looked like they might have a hilar nodule, so that everything was focused on cancer until the patient dropped dead with the third pulmonary embolism he'd had, because the pain he'd had from resting from the flu-like illness was a DVT. And so it's really important that if you've got someone with leg pain, to go through the NICE guidance algorithm for managing suspected deep vein thrombosis. And so failing to think that a leg problem could be a DVT, get the D-dimer done. If it's normal, we know it's not. If it's positive, well, they end up having a duplex scan. That's safe for the patient. And obviously go through the Wells score. And so look through those NICE guidance. So it's failing to examine the foot pulses is the main one. Failure to think of the vascular and another cause being vascular. So the patient with sciatica, just make sure you look at those foot pulses. Failing to kind of basically follow NICE guidance, and they're the two main ones, I think, the diabetes and DVT pathways. And then which I think is rather unfair when it's happened, is a patient's been seen, so they're usually diabetic, they've got some arterial disease, they've had an angioplasty, let's say, they've had a bit of the toe nibbled away, they've been discharged by the hospital, and then primary care's held on to them when actually they've deteriorated, and they've not sent the patient back saying, this patient's, you've not made them any better, docs, or actually they've got worse since you sent them back home. And the poor old GPs have got it in the neck because actually the secondary care team didn't do their job properly. So they're the things to watch out for in the vascular world. So James, have we got any other questions for now?
Yes, so Ferry's asked about, they see a lot of elderly patients with dusky and painful toes, actually sort of generally dusky and painful toes. How might we go about managing them? I suppose part of that question is, could you have very peripheral vascular disease? Could you have sort of like end vessel vascular disease? Is this a problem as a presentation?
Okay. So I'm going to give you, thank you for the question, because again, a very good one. So I'm going to give you some of the scenarios where we kind of get frustrated in clinic and wonder why on earth the patient's been hauled out of their nursing home, where they sit all day in a chair and they're in a wheelchair and they're suffering from brain failure. And we're being asked to look at these slightly blue toes. So I'll still bring you back to, well, have they got a pulse? So that's the first thing. If there's a pulse in the foot, the fact they've got blue toes is something called acrocyanosis. And if you remember, cyanosis is when there's more than 5 grams of carbon dioxide in the blood. And that happens in people who don't use their legs. So people who are paraplegic, people who are spina bifida, wheelchair bound, the body is essentially saying it's not worth me sending that much blood down to the feet. So the actual flow rates are relatively low through the foot vessels. All the oxygen gets taken out, replaced by carbon dioxide, and the toes take on a blue hue. And that's very common in the elderly who are just not walking around. So have a look at those feet. And then actually what I would tend to do, this is what I do in clinic to demonstrate everything's fine, is lie the patient down if you can. And I appreciate that's not always so easy in the practice with the amount of time you've got, and lift the foot up in the air. And if when the foot goes above the level of the heart, the blueness disappears, but the pink stays, you know they've actually got good arterial supply to the foot. And the reason it was blue is now the venous blood's drained away more quickly. So it's a bit like that Berger's test that we were taught and nobody ever uses quite right. But if you've got those blue toes and the patient's not in pain and they've got no black bits, then it's most likely to be just sluggish flow and acrocyanosis, and they don't need referring. And that also brings me to one of my other slides, which we can go on to ulcers in a minute, but you might have noticed when I put red things up, these are bits I really want you to remember. If you're going to refer us patients, then we've got to have a realistic expectation about what we're going to do. So sometimes we get referred patients who are from the nursing home, who can't consent. They're not really going to improve with anything we do, and it does just block up the system. If you are worried about those patients, because some families do tend to get annoyed if we don't look after their relatives in the nursing home, ring us, have a discussion, and if we turn around and say, well, actually, by the sounds of it, even if they came to hospital, we wouldn't treat them, then you've got our air cover as a secondary care team to say, well, they wouldn't touch them, so I'm not going to send you in. The other thing to think about is actually what happens to these patients and to check with them. So, I mean, not necessarily the nursing home, it's just any of the patients we see, is if I send you to hospital, so if the primary care team sent to hospital, one of the potential outcomes of you having diabetes and a foot ulcer and the fact you're still smoking is you may not come home with your leg, because there's a high chance you'll have an amputation. And it really helps us if the patients, and most primary care teams don't do this, but it helps us if you've told the patients who are still smoking with diabetes that you're going to lose your leg, guys. You will lose your leg because that's what smoking does, and that's what diabetes does. So if I was you, I'd stop your cigarettes now, and then there's a greater chance you won't lose your leg in a few months' time. And it's just that working together as a team and saying it is the patients who've got the disease. They're the ones who decide to smoke. I know they haven't necessarily decided to get diabetes, but we've got to help them stop the things that will help them most. So I hope that covers the blue toes bit.
Yeah, I think certainly. That's questions for now. Keep them coming, guys, in the chat.
Okay, so I'm going to go back to what we were talking about right at the beginning. Let me flip back to the very first slide, unless you can pull the things up. So we've got a general assessment of leg pain and peripheral arterial disease. Hopefully I've covered most of that in terms of just thinking about the different reasons for pain when you walk. Remote assessment of leg pain. I hope I've given you an idea on that. Given you some idea on when to refer with the arterial and pointed out when you get sued and how to avoid it. So I'd quite like now to turn to leg ulcers. So these are obviously leg ulcers. I presume you all primary care teams, the nurses are spending ages looking after patients like this. If you look where the ulcers are, these are almost certainly venous. And in fact, the argument from the Royal Society of Medicine, and again, there'll be a link to that in the after lecture pack, is that you should consider every single ulcer that's been there for more than 2 weeks and is not traumatic to be venous in origin, and those patients should be referred to vascular surgery. So the algorithm that has come from the venous forum of the Royal Society of Medicine is, if you have a patient with a leg ulcer, do the ankle pressure measurements, and of course if that's above 0.8, then the nurses should be able to put the patient in some form of compression. If it's 1 or above and they've got pulses, remember the pulses, it's absolutely fine to put them into full 4-layer compression. What we often find is the nurses will not want to put a patient in unless they've seen an ABPI of reading. But if the patient's got a pulse in their foot, they've got an ABPI of over 1, they don't actually need an ABPI. So, but I realize I'm crossing a few boundaries in terms of community protocols. But anyway, leg ulcer, early assessment with ankle pressure, and then apply 4-layer compression. There's loads of compression systems out there now. You don't have to use the 4-layer. There's a device called the JuxtaCure, which is sold by Medi and is available on FP10, which is actually a Velcro system which allows the patient to put it on themselves. They then throw it in the wash every night and it's ready for them. And that's really helpful for those people who are wanting to work, and it avoids them having those really bulky dressings, which usually go on with a 4-layer. But really the advice is if they've got an ulcer, they need to come and see a vascular surgeon. And guess what? They'll have the venous duplex scan, and that'll tell us if they've got superficial venous disease. It'll also tell us if they've got arterial disease, because we can do that all at the same sitting. And then we will then advise that there's nothing we can treat and ask the community team to carry on compressing, or if they've got underlying superficial venous disease, which the vast majority of patients have, we can then do either foam sclerotherapy, if they're very elderly, that's all done under local anesthetic, walk in, walk out, or if they're appropriate, the newer endovenous ablations using lasers or radio frequency. So the other really important take-home message apart from feeling the feet and the foot pulses, is any leg ulcer more than 2 weeks, you really should be getting that patient sent on to the vascular services for assessment. And again, if you're not sure, use the advice and guidance. So has that triggered any other questions?
Well, there's been a couple that came through. So one second, I'm just going to get it up here. The thing is, so somebody's written here as a part of our assessment for foot ulcer. If somebody has a so it's skipping back a little bit.
Yeah,
someone has a monophasic pedal pulse, they're obliged to ask for a vascular referral. But a lot of these people are aged over 90 in care homes. I appreciate your thoughts, and I think that probably what comes to that is, what can somebody that's probably not fit for an operation, what sort of options do we have to help them out?
Okay, so here we are. I mean, this brings this where I got my asterisks, which is where we've got to think holistically about these patients and not just in the binary protocols. First of all, what is the patient's expectations? If they're 90 and in a nursing home, they are not David Attenborough. They're not running around doing things. What are we trying to achieve for this person? And this may be controversial, what I'm going to say. You know, we have just spent a lot of time, effort, and money saving lots of elderly people over the last year. But actually, we are all going to die. And in fact, as an aside, Graham Jackson, who's the GP on the NHS Confederation, he's the chair, he's a friend of mine from years ago, or current friend, he actually starts his lecture saying, I'm looking at the future dead, because everyone's going to die. And do they want to have their last days in the nursing home comfortable, or mutilated by a vascular surgeon because the angioplasty's gone wrong and they're now having bits lopped off? So we really need to rely on the primary care team to say, discuss with the patient, what expectations have you got, and are they actually realistic? So even though the protocol may say measure the pressures and refer, I would argue use the clinical skills as to actually, is this appropriate? Now, if an elderly patient has got pain, then use the analgesic ladder, paracetamol regularly, Nurofen, because there is an inflammatory process to ischemic pain. The gabapentins and amitriptylines often make them do lally, you'll know that. But morphine's pretty good. So just use the normal analgesic ladder for those patients. And accept that some of them will get respiratory depression and may get the pneumonia. And that's, you know, it's old man's friend, I think was the phrase. And then the other thing is, if these patients get an infection in their foot and they start to get septic, and I appreciate this might be very difficult, but if we're not going to do anything to them in a hospital, why give them any antibiotics? You know, is the sepsis from the foot actually the start of the very end for that patient's life? Even though you can give them and it might tide them over. And I suppose this goes back to having living wills and having an idea what the individual wants. And then if they or I suppose their family say, but you must do something, doctor, you must do something. Well, give us a call and see what we say. And there's a range of opinion amongst all vascular surgeons. There are the hawks and the doves. There are those who are going to say, well, what do you expect me to do? Why have you rung me up? And there are others who will just keep going. And if you get a consultant or a registrar who said, oh, send them in, we'll sort them out. You then need to say to the patient, well, if we send you in, you probably won't be coming back to the nursing home. You certainly won't be going home. They'll be doing this to you. You'll have an ultrasound, you'll be on a bay, you'll have to wait several days for the first line therapy, which is an angioplasty. But the chances are you'll probably end up losing your leg because of the severity and age and the like. Do you want to carry on living for as long as possible, even though you might have an amputation and you'll probably be in hospital for months? Or are we going to call it a day and get the family around so you can see everybody you want to? Yeah. That's how I would suggest one approaches the very elderly. But you guys are the experts at that, and I only see those that kind of go through that filtering process.
And I think that's absolutely right, and it does link into another comment someone's made here, that they've said if they don't refer, families put in complaints. And I think it's absolutely what you said, and as general practitioners, primary care, we need to be asking, and earlier on, pre-significant deterioration, what really matters to people and what's important, and then negotiating that with it. But it sounds as if we've still got those tricky cases where maybe borderline, a letter of advice and guidance to yourself sounds like a good way to address that, as to, because then you've got further evidence.
And that's right, James. And that reminds me, we've all got one of these, and most patients and their relatives got them. In fact, they use them to spy on us. I mean, they will actually record our conversations without us knowing, and they'll take photos. But actually get the patient's relatives to take the photographs of the feet and say, thank you very much. Can you ping that to me by phone, the nurse's or the doctor's phone, and send that to us in the hospital? Send it by email. Obviously, just say, I've got this patient, they're 89. What would you do with this? And of course, the doctors are going to say, what pulses have they got in the feet? And I'll keep bringing you back to that. And what does the patient want? And if we then ping back, and the really important thing with the communication is if the doctor on the end of if the consultant says don't do anything, then get their email address, the consultant's email address, write them saying, we discussed this case together. You said to me, blah, blah, blah. Therefore, we're not doing anything. Is that correct? And if they ping back saying, yes, that goes in the patient's notes. The specialist said they weren't going to do anything. That gives you the air cover. And you can say to the patients, but we checked and they weren't going to do anything. So you can be then comfortable that the patient's been managed appropriately, would be my argument.
Yeah, I think that's absolutely right. And it takes quite a lot of strength. And I suppose, from the general practice side of this, if people need support in having that conversation with family, district nurses and the like, you speak to your GP, speak to the patient's GP, who might be able to help back you up on that. Yeah. And there's been a couple of questions about the leg ulcer aspect of this. So are the guidelines, as you've suggested, to 2-week leg ulcer that hasn't healed needing a referral, has that been adopted widely across the country? Because Kahindi, who I suspect doesn't sound like maybe it doesn't work in Nottinghamshire, has said that I don't think our local vascular team would ever accept a 2-week-old ulcer. It sounds like they should, but do you know if that's been well accepted amongst vascular surgeons? Okay,
so there's a few things I could say. So it's a brilliant question. It's a brilliant challenge to that. You've got to remember that vascular surgeons, we train because we like doing aneurysms and we like doing big heroic stuff, but that's all done by radiologists now. And leg ulcers is going to be foam sclerotherapy or endovenous ablation. It's not very exciting and you can't be heroic about it. But actually, the morbidity and the cost to the NHS of leg ulceration is I think it's $1 billion a year, something like this, huge amount of money. So if you think about it's what's real money, but how many of your district nurses are spent and community nurses are spent going around to patients and dealing with their leg ulcers, which had they been referred to a vascular surgeon, might have been fixed and the ulcer healed in a few weeks. So I think you have to say this leg, the Royal, there'll be a link to it, the Royal Society of Medicine and the Venous Forum. And in fact, there has been a cross-party committee meeting in Parliament about leg ulceration. But actually, because the burden is so high, obviously it's, there are interested parties, but how else do we improve patient care? I think you need to say this patient's got a leg ulcer. I think it's venous. We know that if they're referred earlier, the ulcers stop getting bigger, they heal quicker, and we know that with treatment of underlying superficial venous disease, and there's a big study that was done on this called the SCAR study, that the ulcers stay healed. So that's got to be better for the patients. So I would ignore the grumpiness of the vascular surgeons and say, I'd like you to see this patient. Their leg ulcer, I think, is venous because of where it is. They've got normal pulses. Please, will you see them and treat them? Now, with my commissioner's hat on in terms of secondary, you guys are in the hot seat. And I know with the ICS is changing, but you determine what happens in hospitals. And if you turn around and go to your governing bodies and say, guys, we're not getting the response we want from the secondary care team, well, the contracts team can say, we want KPI'd any leg ulcers we send in, we'd like them fixing, 95% of patients have got to be seen within 2 or 3 weeks.
Yeah.
That's the mechanism by getting patient care better, and tell the contracts team that's what the community want.
Yeah, well, I think it's quite right, and I think that probably answers the next couple of comments we've had in the chat as well. So Deborah's saying that we generally would be told not to do anything until 8 weeks. And actually, should we be relooking at things? And from what you've said there, I think yes, just really should be looking at it. And Gahindi, who works in Derby, would like to. It sounds like there's a great quality improvement project off the back of that, because they're finding that they're having to fight for every referral accepted across Derby.
Okay, so for the Derby team, get hold of Ganesh Kuhan, who's one of your consultants. He's very interested. He's one of my ex-trainees. He's very interested in the management of venous disease, including in obese patients. And if you started to direct things at Ganesh, and he started to becoming the leader in Derby for managing patients with venous disease, then his colleagues will start adopting the way he does things. So that would be my advice. You probably won't forgive me for dumping them that on him.
Well, we'll keep your name out. We'll keep an eye out for your name, Kahinde, on the future, the new referral system over at Derby. So, and we've got one final one here. Is two. One is when should we consider? I must say, I've never heard of it before. NATH.
Yeah. So basically, it's Trental. I use its trade name. It's a drug that's licensed to try and improve a bit of blood supply down to the foot. It's a prostaglandin analog. We tend to use it when there's nothing else that can be done. So we use Iloprost, which is the infusion version essentially. And I suppose if you've got a patient who is in pain, has been to see the vascular surgeons, so I don't think you should be prescribing it without the patient having their arteries assessed. If the vascular surgeons have said the whole artery, it's blocked from femoral artery down to the foot, there's no way we can do a bypass. It's either analgesia or amputation. It might be worth trying that for a while. But I would argue you should probably never be starting it in primary care because you need to have the vascular assessment using the ultrasound.
In Nottinghamshire, it's number 2, so it has to be initiated by a specialist. I just looked it up.
Very good. Okay. So unfortunately, lots of what we do is still based on what the facilities and resources we had in the 1980s and 90s. I mean, an ultrasound machine was like gold dust in the 80s and 90s, plus they weren't very good. Now we don't have radiologists do it. We have specialist vascular scientists who are really brilliant. They're doing thousands of scans a year, and they're quick and they're high quality. And in the past, we would have to do an angiogram to assess someone's circulation. Now we can do it with ultrasound. So it's painless, it's risk-free, and very accurate. So really, we should, if I work Department of Health, I'd be pushing that all vascular disease is basically, they need a venous duplex. We need to look at the blood vessels, and going back to those people who have health insurance or decide that they want to pay for it themselves, the gold standard they get is an arterial or a venous duplex. And I'd argue everybody should be afforded that, but that requires a bit of a change in both primary and secondary care to allow it to happen. And of course, in the background of that, we've got all the cancers, the cardiac and everything else that's going on. So we've got to be mindful that we're in a little silo here with me chatting away.
But I think there's certainly worth knowing these things, and especially because there'll be people, that are being involved in commissioning within this talk, listening in, and actually being armed with that knowledge, and can be helpful to so we know what to ask for. Because certainly, and I'm sure that people are experiencing it across the country, but access to scans at the moment is slower, is more difficult, just because of the pandemic. But in fact, even pre-pandemic, it could take a very long time.
Yeah, it is difficult, but of course, there's a subtle difference. Is most of the imaging that's requested by primary care goes through radiology department, and we've got a massive backlog. I was talking to the head of service. I mean, the number of MRs, they're way behind and reporting, and that's partly because there's people are requesting scans when in fact they should be using their clinical skills. Some people are doing it because a radiologist has told them to do the next scan. Some people are doing it because they're just worried about missing something. But vascular scans are actually done by the vascular department and are a different, certainly in Nottingham it is. I think in Derby, it's years since I worked there, but I'm sure that they've got their own vascular lab, which is separate from the general radiology team. So, we come as a package as a vascular team. It's not just a vascular surgeon, it's vascular radiologists, vascular scientists, vascular nurses coming as a team.
Brilliant. Grand. Yeah, so there's a couple of other things, we'll come back to them.
Right, anything? Well, no, God, I was just kind of wanted to know whether you all wanted to play a game for a while, you see.
I think a little bit of a game would be good at the moment.
So anyway, so if you're still with us, as it were, so I'm going to show you a few slides, and I think James and I decided you might want to just ping up what you think. But what's your kind of spot diagnosis? What features support it? Then going back to the message about what else could cause these problems, and should you refer, and if so, to whom and when? And then a guessogram as to which leg pulses might be palpable, which is quite difficult because you can't measure them remotely. So I think there's about 8 or 9 slides, but you can have the pack and you can play with them later if you want. But if I just ping that up, and then you might want to just respond on the chat as to what you actually think the spot diagnosis is with what's going on in slide A.
It looks sore.
But it might not be.
It might not be sore. That sounds worse, if anything.
And it's quite possibly that's not sore at all.
Yeah.
So hopefully some people got, but I'll take you through this. So what we're looking at is obviously a left foot. It's got all the toes. That's the first thing to think about. They're all 5 there. It's very dry and flaky. You see, it's not a moist skin. There's a black bit with a bit of bone sticking out in the middle toe. There's a crusty bit on the index toe. I call them index toe rather than first and third. And then you've got a black bit overlying the proximal interphalangeal joint of the great toe. So what do you think the underlying disease is this patient's got? Another question. What's coming up then, James? I can't see the answer.
Well, so I would suggest that our participants just feel free just to dive in. I think it's all about learning. So I want to see the chat going, lots and lots of things. So we've got arterial ulcers, gangrene, and Cyrus said, our pulse is present. That is the key. So
good. I'm learning. Excellent.
Exactly. Peripheral artery arterial disease. Lots of people have said diabetes.
Good. Right. Well, excellent. All good answers. This is a diabetic foot, which is why I said they might not be able to feel anything.
Brilliant.
So that it's dry and scaly, because if you remember, diabetes knocks off the sympathetic nervous system, so they don't sweat. That means they get dry, cracked feet. It is peripheral arterial disease because the damage is at the tips. And when I'm talking to the medical students, I ask them who lives in the furthest room from the boiler, and is your room hot or cold in the winter time? And it's the coldest room because, of course, it's furthest from the heart, furthest from the boiler. So peripheral arterial disease will nearly always manifest as lesions on the toes. And so, yes, so this is a patient with diabetes. They've worn away the tip of their middle toe. There's a bit of phalanx sticking out. That's this bit here. It's a bit of bone there.
Oh,
They've worn because their foot has changed shape, because you've got the muscles change, you get deformation of the muscles because of the myopathy. They've worn a hole on their foot, so they ought to be having properly fitted shoes. But this person is probably not, they're not unwell, it's not septic, but they need to be referred to the joint diabetic foot clinic where they should be having an arterial duplex scan. If they've got arterial disease, and they almost certainly will have with no pulses, then we would assess them to see if we can improve the blood supply. And even if we can't, and we can't sometimes, they need to have moisturizing to keep the skin from being cracked, and they need to have offloading. And then we would need to think about, do we do anything with the bone sticking out, because it's a potential risk of getting infected at some stage. But we might not do anything at the moment because it's not causing a problem. But this is a very, this foot's at real risk at the moment. Okay, got the idea of the game? Like another one?
That's it. Comments in the chat. Oh gosh. Not for the squeamish.
Oh, I can make it a lot worse.
This is why we become GPs. We don't have to look anything too gory.
So again, it's the same thing. What's the spot diagnosis? What pulses do you think this patient will have? Should they be referred? What else are you worried about? Don't have anything coming up on the chat about it.
So Angela's diagnosis is gross. Osteomyelitis, pulses, osteomyelitis, osteomyelitis. Yeah, people saying a very pale foot. Well, I suppose it sort of depends on what the foot was, what color it was before. But
yeah, and that's different. So that's really good again. So this is an osteomyelitic foot. Well, it's just the great toe actually. Patient's about 32. They've got fantastic pulses, but they've worn a hole in their foot. You can see it's a bit dry around the toes and the like. They were a bit septic. I think their white count was 16, CRP was 254. So is this one to give a bit of antibiotics in the primary care? What would you do with this patient? I suppose that's my next question for the team is, should we give them a couple of days worth of antibiotics? What should we do?
I'm referring them in straight away.
So that is definitely a same day. Don't even tinker with it. Because if you look at, and I'm going to refer you back to NICE guidance on this one, which I'll just flip to this. Okay, NICE guidance, which is 2015 updated 2019 for diabetic foot infection, is if they're really unwell with that sepsis, they must go in on the same day. If it wasn't quite so bad, you might give them some more antibiotics. And again, there's guidance from NICE as to which ones to select. But the message I've taken from this, and this is where the primary care team have come a cropper, is not reassessing the patient the next day. So if you give antibiotics orally, or even if you give them intravenously in the community, if it's not better the next day, you've got to send them in. And again, and this would be a person with a foot pulse. If they don't have a foot pulse, I would probably be saying this person's got to be sent in within 24 to 48 hours so they can have inpatient antibiotics and revascularization within the week. So again, it brings it back to, if there are foot pulses, manage them with the antibiotics, check the next day, and if it's not getting better, send them in. If they have no foot pulses, start the antibiotics, send them in, because they need to be assessed.
Who are we sending them to? We send these guys to orthopedics, vascular, or medicine?
But if vascular, if it's orthopedics are pretty much given up, certainly in our area. But the point is, if there is no pulse, it's got to be vascular. If you cannot feel the pulse, you need a vascular surgeon to look at them. Otherwise, they'll just wait. Don't send them to podiatry if there's no pulse. We're going to keep going back, feel the feet. If they've got a foot pulse, then you might be able to manage it just with antibiotics and local debridement.
Just from a practical point of view, not in Nottingham, in NUH, is out of hours, is that just to be to general surgery, or is that...
It's vascular. Vascular is available 24/7. So we have a vascular, there's a consultant available all day. There's a registrar available all day till 8 o'clock in the evening. And at night time, it's either a vascular registrar or a trauma/vascular registrar. So they will probably accept the patients. And we have the surgical assessment unit where the patients stay. If they're fine, we check them, or we'll check them out the next day. But obviously there are the bed crises and the like, but it's just those general rules of have they got arterial disease and feeling for the pulses.
Brilliant.
So how are we doing for time, James? I'm very aware we're kind of 8:45 now.
We've got 15 minutes left.
Okay. So here we are. Here's another one. Which foot's ill? Which one foot's got the problem? And why?
If I put things in the chat here, I don't know the answers. Okay, I'm just joining in. So just oh, we've got two for right, 3 for right, 1 for left, 4 for right, 1 for left. Somebody said both. You can't hedge your bets there.
Well, I could do.
Left. Okay, so it's marginally right is the winner at present. 2 people have said both.
Okay, all right. So in my view, right is the correct answer. But the point is, we've all been trained that an ischemic foot is white and pale, isn't it? But actually, when a foot is absolutely desperate for blood supply, you get vasodilatation and you get this redness. And if you look at it, and hopefully we'll have some of these in the next couple of months, it's like an evening sunset, which is red. And we call it a sunset because it's got that redness you get on a lovely summer's evening. And it's also a foot that's waving bye-bye to the world. So this patient, you can also see there's some necrosis of the great toe, apart from the dryness, but they have no pulses. And in fact, they've got no decent patent vessels from the femoral artery downwards, yet their foot looks red. But actually, when you feel the temperature, it's a bit cooler despite being that color, and there are no foot pulses.
I remember in medical. Sorry,
you go ahead.
I remember in medical school they're telling us about the 4 Ps, which was it pale, pulseless,
paraesthetic,
and perishingly cold, and apparently possibly red as well.
But to be perfectly honest, I think it's 5 or 6 P. I can't remember how many Ps.
5 or 6 Ps. They've added some.
The only people who cause the Ps, or the only patients who get the Ps nowadays, is those who've been stabbed or shot.
Oh, right.
Because it used to be in the days of emboli onto perfectly healthy vessels, but it's very rare to see an acutely white leg unless there's been an injury, or very occasionally it's someone with a popliteal artery aneurysm, but they tend to present in a slightly different way. So all the stuff that's in there about the Ps, it's years since we've really seen it, to be honest. Talking of feet, here we go. What's up with that one? Anything coming through on the chat yet?
So we've got necrosis, gangrene, peripheral artery disease, PVD with gangrene. Somebody's written sepsis, possible sepsis.
Oh, yeah, okay. Yeah, I can see why they might say that.
Here it is. Looks like little toes about to fall off. That doesn't look very good. PVD.
Okay. So when we say PVD, I'm presuming meaning, they've got atherosclerosis, maybe claudication. Yeah. But you may see this, and we certainly have some people who've had it missed, but actually this is atheroembolization. So what's happened is this patient's actually got an aortic aneurysm with a whole lot of gunk in it, and they've got their foot pulses are present.
Is that trash foot?
That's trash foot. That's what trash foot looks like. So this is where my rule of if they've got pulses, it won't be vascular disease is completely wrong. Because this person will have probably quite good pulses because of an aortic aneurysm, but it was full of rubbish. You get a whole load of porridge-like thrombus in the aorta. And if you get a bit of turbulent flow, bits break off, and that's what it looks like. So people have, just going back, we've used this term gangrene, and it's just to qualify, there are two types of gangrene. I think I might have got rid of my picture one. So there's the dried black mummified one, which will be in the non-diabetic patient, the little old lady with a black toe, who may, as long as they've got no pain and they may have no pulses, we're probably not going to want to do very much to that, because that's dry gangrene. But then there are those patients with diabetes who've actually got dead tissue, the gangrene, plus superadded infection, and they're the ones we really need to be seeing. And again, if you're in Leicestershire, you'll end up having that toe operated on in the middle of the night. So the vascular team in Leicester are now based at Glenfield, and they will bring an entire operating team in just to deal with the toe. And that's why they're getting better results. In Nottingham, we have to fight with neurosurgery and everybody else. And the patients with toe problems currently don't get done so quickly. So it's just the subtlety between gangrene. There's dry gangrene and the wet gangrene. Okay, last slide from me for this one. What's going on here? Oh. And what pulses are present?
So somebody's written, we've got so far, we've got arterial ulcer, no pulses but an infection, chronic venous ulcer. So we've got 2 for venous ulcer, 1 for arterial, 3 for venous ulcer, more venous ulcers. Oh, somebody's put question mark biopsy. And again, I seem to, looking at things, and I remember being told to see sometimes.
Okay, yeah, so yes, so it's good that, so I think that's brilliant whoever said that, because they're thinking, what else could it be? All right? And I've certainly had patients refer up with a massive squamous cell carcinoma, which has eroded into their ankle joint, which has been sat on for ages. But if you look at this, it's got lovely pink granulation tissue. I say lovely in kind of the vascular way of saying lovely. There's a few greeny bits. Well, that's Pseudomonas. We like Pseudomonas because it keeps the nasty bugs out. It's around the ankle. And I'll, just as an aside, I'll explain why venous leg ulcers are around the ankle. And the toes, and I know you can't see it completely, the toes don't seem to have any problems with them. And this patient's got a pulse. So this is a venous leg ulcer. It is chronic. It's been there a long time. But what do they need? In fact, you probably can see what they've been having, because there are some telltale creases.
Yeah, slightly speckled look.
Yeah, also, well, just these bits here, they've probably been in 4-layer compression, and this is a dressing change. But so this patient probably doesn't have this. This is not the arterial, because it's not the furthest point from the boiler. That would be the toes if it was arterial. However, in fairness, the person who said arterial, it could be mixed arterial and venous. And again, guess where they need to be sent for assessment?
There you go. Somebody's put that to see you in clinic, says Bakula.
That's right. They need to see they actually need to see a vascular scientist first who'll do the scans, and then either a radiologist to do the angioplasty or a specialist nurse practitioner to do the foam sclerotherapy, and the vascular surgeon can stay on the golf course. Now, just as an aside, just to give you the kind of things where you can tell your patients and how knowledgeable. For those of you who did physics, do you remember how you measure the pressure in a tube and where the pressure is at its highest? Well, pressure is inversely proportional to the radius, and the most narrow part of your leg is the ankle. And so if you think of your leg as a pipe, and the ankle's the narrowest bit, and you've got a head of pressure that's 1 meter to 1.5 meters, that's where the highest pressure is, which means you get the capillaries leaking, and you get white cells moving out of the capillaries. They then kind of stop and get eaten up by macrophages as to the red cells, and that gives you the brown discoloration, which of course we call the venous skin changes. That leads to the eczema. That leads to a reduction in oxygenation of the basal cell of the skin, and then you get the breakdown in the ulcer. And that's why venous ulcers happen at the ankle, because it's the narrowest point. And the reason the patients end up with legs that look a bit like the one on the right, that look like a champagne bottle, is you get dense fibrosis around the ankle joint. That means the ankle gets stiff, which means the patient can't move them calf muscles. The calf muscles are designed to help pump blood back up the venous system. And of course, if you can't move your ankle and you can't move your calf muscle, your venous disease gets worse and it becomes a vicious circle. So those patients with leg ulcers, they need referring early before they get the fibrosis, which means that their disease is pretty set for them. And if we can get to them sooner rather than later, the chances are we'll have fewer patients with champagne bottle legs like that.
I mean, you've mentioned the venous sclerosis a few times. Is that, could you mention a little bit about how that works and how that happens? It's not for at least for venous ulcers, not something that I'm particularly au fait with. So I expect other people have had the.
Okay, well, it goes back to the pressure. So if you may remember from medical school, there's a diagram of a capillary with arterial pressure at one end, venous pressure at the other end, and then you have hydrostatic pressure pushing fluid out, and osmotic pressure from the proteins in the blood pulling fluid back in. When you have varicose veins or venous hypertension, the pressure gradient changes from across the capillary from steep to much more shallow, which means there's more hydrostatic pressure to push fluid out. Now, we don't fully understand the mechanism, but there is an inflammatory component where white cells get stuck to the endothelium and then they migrate out into the interstitial tissue. There's also the spaces between the endothelial cells open up and red cells go through. The red cells then cause an inflammatory reaction, which means macrophages eat them up and then they just sit there, and I think of it like a food baby. They just don't want to move anymore. As a result of the inflammatory processes, you got fibroblasts invading, just the normal mechanism of healing. And then once you've had fibroblasts in, they tend to pull everything together, and that gives you the inflammation and the hardening, which gives you lipo, fat, sclerosis, fat hardening. And you get that as in the skin as well. So it's lipodermatosclerosis. So the mechanism is all triggered by an inflammatory response, which the evidence suggests is related to too much pressure at the end of the capillary because of poor venous drainage. And that can be triggered by superficial venous disease, which is the most common cause. I mean, this patient will just have a great saphenous vein that's incompetent. And all they needed was that treating several years before, and the chances are they wouldn't have ended up with a leg ulcer like as bad as that and a leg as bad as that. So hopefully that, in a nutshell, explains the mechanism of why you get that hardening. And it is inflammatory. And it does hurt patients as well. People say veins don't hurt, but they do hurt.
Do you think the move away from treating sort of superficial venous disease, because often it's, we don't tend to treat varicose veins or things like that. Do you think that's going to have a knock-on effect into venous ulceration later in life? Because I seem to recall when I was 15 years ago, I was at medical school, we did quite a lot, and now it's sort of fallen off the.
I think the real difficulty, and it's a commissioning decision, and part of Nottinghamshire, the treatment centre, we had to help the commissioners because of the cost and the like. There's no evidence there is increasing numbers, and that's probably because 90% of patients with varicose veins are never going to get an ulcer. So I'm not sure we're going to have more. What I think the commissioning guidelines has done is the default position when I talk to patients who turn up at places like the Park and the like, who are self-paying, and then I try and push them back into the NHS when they've got this scenario, is it's almost a default that you've got varicose veins, therefore we're not going to refer you at all. And it's missing if they've got venous eczema, if they've been putting cream on to deal with the eczema, that hits the criteria for the East Midlands, which, just to go over it again, is 2 episodes of thrombophlebitis, venous eczema, liposclerosis, which is the hardening, or active ulceration, and they all allow referral. But there are certainly a few patients who come through the independent sector who just haven't been referred at all because the message seems to have not got has been misconstrued that we're not interested in seeing any people with venous disease. And this goes back to, and it's the real difficult thing between the NHS and independent care. You know, the cost of having your veins treated, if you're paying for them, can be as little as £800. I say little. The NHS, you know, the taxpayer pays between £1,200 and £1,300 to have a leg treated with venous disease. So actually, you can treat someone for less than NHS tariff if they've got varicose veins they don't like the look of. But it's really thorny. I mean, in an ideal world, I would argue everybody with varicose veins should be referred to a vascular surgeon who should assess them and then should say you can't have it because you don't meet the criteria you do. Unfortunately, you can't trust a vascular surgeon because they want to put things on their operating list. And they won't work for the commissioners because they're not employed by the commissioners. And that goes back to the politics of how the whole NHS is. If everyone was working for the same team and didn't have operating lists to fill, we'd probably actually have a better run service. But while we're in two camps, and again, that brings back to commissioning and contracting and the like.
Well, that, and I think also having good discussion between primary care and secondary care, which is why I think that these learning opportunities, and to have someone, you know, that be so honest and helpful come and speak to us in primary care is really helpful. So thank you so much for that today. We've got if you wouldn't mind questions, because it pipped in at the end there.
Yeah, no, that's fine. Go ahead. Yeah.
And Carol's written, do you think that early intervention for venous insufficiency would be financially viable as a preventative measure regarding venous ulcers? So if we sort of identify people earlier.
So I don't know the answer to that. The person who I would defer to is called Professor Alan Davis, who works out of Imperial. I'm pretty sure Alan has done the maths, and I think the number needed to treat would be so many that actually it wouldn't stack up. And then we've also got to think that, you know, the politics and the pressure groups, people don't care about patients with ulcers and veins because they're often the elderly and tough luck, at least you're walking, because of all of the pressure is, rightly or wrongly, is the cardiac, the children and the cancers. And I'd argue, you know, more recently, we need to be looking after spending our money on prevention. And I know the question's about prevention, but there's just health education and giving people the power to look after their own health. So I may well have ducked the question. I don't know the answer about the money, but actually with all the other competing interests, veins are still going to come a long way down the priority list, I'm afraid.
Brilliant. Well, thank you so much. I think that was the last question that just pipped in, and there's so many really great comments in the chat and thanks. So again, I'd just really like to extend my thanks again to you, Mr. Braithwaite, for a really interesting and enlightening talk this evening. It's been really great to have you, and yeah, thank you so much.
It's a pleasure, and thank you very much for your attention and your time. And as I say, hopefully you've learned some stuff. It'd be good to get some, if you quickly write down what you've learned, then I know I've got a message across. And that's a way of getting it into your long-term memory for the future.
Well, you're absolutely right. So if I could encourage everybody to do the feedback, which will have been popped in the chat, and we'll just pop it back up again now. There is a bit there for what have you learned and something you'll take away from this. And I highly recommend you do that and make a bit of a commitment to yourself of something that you will change. And there's also this really great website called My Future Me, which again, or Future Me, sorry, which you can click on and you can send yourself a message. So you can send yourself a message for a month in the future of something that you promise that you'll change right now, so that you can revisit that and be like, well, did I actually do that? Have I actually made a change? And hold yourself accountable a little bit for those changes. It's so important for that learning process. And as you say, coding into long-term memory. The feedback's really important for us, and as much information you can give us, good or bad. You know, hopefully everything's been good, but we want to make these events more often, better, and just bring things and just bring you the things that are going to be the most helpful. So hopefully today's been one of those. It's certainly been super helpful for me, and thank you so much, and enjoy the rest of your evening.